Hello, everyone. Pleasure to be here. As Chris said, I'm from Arcweb Technologies. We do strategy, design, and development of enterprise software, and we've been a trusted partner of over 80 companies to help them launch a new digital product or introduce new technology into their business. We focus primarily on healthcare. Locally here, we've worked with Penn, CHOP, Tabula Rasa Healthcare, which recently IPO'd, Homestead Smart Health Plans, a number of venture capital and private equity-backed companies. And we're also Epic partners. So Epic Systems is an electronic health records system, and it's used by all 20 of the top 20 hospitals listed in US News, including Jefferson. Our perspective is multidisciplinary. We started off in financial services. We expanded into healthcare. A number of people at Arcweb have worked in healthcare. I used to work doing AI and drug discovery about 20 years ago. And from that perspective, can easily say, like Dr. Klasko's telebanking example, healthcare is easily 10 years behind other industries. And so this short talk is called Hacking Healthcare. And my hope is that you take away a few things that you can use in your organization. So Dr. Klasko did some great framing. Here's some additional challenges that we think really highlight where the patient experience is one of the bigger challenges. So only 8% of Americans are receiving the recommended preventative care. And 70% of all deaths, 7 out of 10, are caused by preventable chronic diseases. So the solutions, arguably, perhaps might be simple for some people, diet, exercise, things like that, but the scale is so massive. And that's what makes it exciting, and that's because the opportunity is so large to transform the industry. So this is a system architecture diagram could be a telehealth platform. This is a modern healthcare system built in the cloud. And if we ask, why is it so hard to transform the patient experience, it is definitely not this diagram. So what's hard to change in the industry are the overall business model and the regulations that impose part of it. But what we can change is the human architecture, the organizational architecture, and the way that we communicate within our organizations, as well as the culture of risk that permeates these academic provider networks. I'm going to talk a little bit about those. So here is a semblance of some human architecture in a large-scale provider. And on the right-hand side, we have core IT operations for the health system. So in the middle is the EHR system, the electronic health record, and that might be maintained by the vendor themselves. And then just outside of that, you have the group of people that does the EHR implementation, support, and the training. And this group in some of these provider networks is hundreds of people. It's a small army of people that help to manage, maintain, and support this infrastructure. And then beyond that, you have what is now sort of a modern day CISO Chief Information Security Officer, which imposes the HIPAA compliance, audit controls, and things of that nature. And then beyond that, you have the traditional IT organization that's trying to function within it. So the organization is pretty large. So if you're trying to do anything at a scale that's going to address the massive scale of the problems and the challenges that we have, you need to be able to penetrate that large blob right there and get right into the EHR system. Now I'm going to switch and just talk about the research part of the organization, which we've seen in a lot of these health systems. And in some ways, that research organization might entirely mimic the entire structure of the right-hand side. And the research organization is oftentimes viewed as a revenue-generating part of the organization, brings in money. It's also run by high-powered physicians. And they have a lot of cultural clout within the organization, so they can get a lot of things done. And if I contrast that to some of the small pockets of innovation that are happening in some of these health systems outside of research, we'll see that some of them might be an innovation group, they might be a digital group, but in a lot of cases they don't have the resources that they need, either the cultural clout of the organization and some of the high-powered physicians, and a lot of times they're led by business people and not physicians. And there's almost no pathway in a lot of these into the EHR system. So if you want to do something beyond pilots or things like that, you really can't, because you can't tap into the scale that's necessary. So, and in my experience or viewpoint, most of the things that are involving patient experience are happening more in these innovation pockets and people that are trying to address it. And it's also the group, in a lot of cases, that doesn't have the clout or the authority or the resources to get it done. So if you're a healthcare executive on the right-hand side of this diagram in core IT operations, it's really easy to say no to pretty much anything that comes along. Some of the example no's that are frequent are that it doesn't meet a high priority clinical need today. The today part's important. We're not going to get paid for the additional services. It needs to be integrated into the EHR at stage 1. Let's see what our EHR vendor says about this. And my favorite is the EHR will be providing this exact functionality several years from now. And it's usually not said to be several years from now. But the reality is that once you put the roadmap of the EHR deployment, or the EHR's product roadmap, put that next to your deployment roadmap, it might be 3 years before the care team actually has the solution that they desire to have at this particular point in time. Not only that, it might not even work the way that you're intending it to work. So, if you take a group that does not have a lot of authority, you mix that with a culture of risk aversion in a lot of these academic institutions, and then you juxtapose on top of that a duplicative EHR roadmap, you get an industry that is 10 years behind, and groups of people that are talking about things like telehealth when we've had telebanking we don't even talk about telebanking anymore. So if the goal is to disrupt the patient experience, then the places where the innovation is happening should have the appropriate authority, the cultural clout, and the resources to get the job done, even if that means taking the risk of doing something duplicative of what the EHR vendor might be doing. That's it. Thank you.